Are you guys ready to get started?
Yes.
I am recording. Fantastic. Yes, sir.
Could we clarify the whole bugs and drugs, what we're covering this test? I wasn't quite sure.
Perfect. Yeah, so this test is going to cover the first PowerPoint, right? So all the bugs and drugs and stuff, the ID and misc agents, that PowerPoint, up through ENT part 1 and 2. Okay? That is a double-edged sword in regards to the fact that will decompress this test a little bit. We'll put a little more material potentially onto the next test, which does include some cardio. Cardio is no walk in the park, you know. Bugs and drugs is probably arguably more difficult, especially being your first test. However, I think in the end you guys will probably appreciate having that little bit of decompression there, okay? So again, up through ENT will be the end of the material. I'll see what I can finish today, and then if I have anything extra, I will finish that up the following session, do the review, and then if I can start anything off, I might try to. We'll see how that goes, and then your test will be on the 19th. Everyone okay with that plan? Any strong objections? Otherwise, I have to rush a whole lot, and I might like record like an extra video, and you guys have to watch it on your own time. And didn't think I'd have any takers, so I will go ahead and go with that. Unless you want to vote, right? Any votes? No? Okay, no votes. Just kidding. I make the executive decisions around here. Anyway, so I just went to a conference about exam writing. You can tell how nerdy I am because I can say this was an incredible conference. I get to learn all about psychometrics. Anyone ever heard of psychometrics before? I think it's a field really I was destined for in another life, just based off of the name. But I was very impressed by these people who were using the analytics of testing to try to figure out, like, is this a good test question? Is this a bad test question? I will tell you one of the things I did glean, because again, this was done at NCCPA, people to write your pants. One of the interesting things I did note is that we were asking about, and of course I've never taken pants, obviously. However, I have pants. I don't take the pants. But I will say that one of the things they note is that as far as answer choices go, they go between 4 and 5. They have found that it really doesn't make a big of a difference from a test taker's perspective as far as it being too distracting to have that extra answer choice. So who's to say we chose to do 4 at another university? I've done 5 before. Probably doesn't make a whole hill of being of differences. The one thing they did say is that if you were to guess, if you were to randomly guess an answer, if you didn't know what it was, do you think you'd have an easier time if you only have 4 answer choices or 5? It's 25% chance if you just did it on 4, right? So they say sometimes that limits, like, you know, how much utility the guessers, not that you guys would ever be a guesser, right? Always know the answer. But anyway, the other thing that I did note, though, was that the fact when talking about drugs, they only put the generic on the pants. They don't put brand names. The reason why they do that is because anytime you change a question, all of the previous stats, right? And again, the stats are very important for that sort of test to make sure they have a valid test question. They would have to take that question out and start over the whole new set of stats, right? The other thing is that if a brand name was discontinued, is no longer, you know, clinically available, then they have to change that question. Again, you have to throw all the stats. So while I will continue to put brand and generic, because I think clinically you'll see brands out there, like you're going to see that out in the real world. Just know that for the pants, you need to know the generics, okay? So just to put a little extra stress on you for 2 years down the road, right? Anywho, lots more stuff that you guys don't have to worry about too much, but I should be writing even better exams. Not harder, but better. So we'll see how that goes. Any questions from previous material that we covered? All right, we're going to continue on. We're going to finish up the ENT stuff today. So I'm going to finish up the antibiotics. We'll talk a little bit about antivirals briefly, and then we're going to move into something you're going to run into very frequently, especially, you know, a lot of these products we're going to talk about towards the latter half of this is going to be a lot of over-the-counter products, and it's a lot of things that patients like to self-medicate with, and it's good to know something about that so you can advise, like, when should they use it, when shouldn't they use it, because the problem is if you don't ask about things like over-the-counter medications, you don't get a full med history. They could be taking things that are counterproductive to the therapies you're trying to start on them, could be counterproductive to their other disease states, and we'll talk about those points there. Anywho, we're talking about otic antibiotics, right? So what are some examples of otic antibiotics we're using? Ciprodex, which is a combination drug, right, of what? Ciprofloxacin, which is what kind of drug? Fluoroquinol antibiotic, right? And then plus dexamethasone, which is what? Steroid, right? What's the point of adding a steroid in for that ear drop? Anti-inflammatory, right? So if you have this nice swollen, red, painful ear, it's going to help to decrease a lot of those symptoms there, right? Doesn't necessarily get rid of the infection. That's what the Cipro is there for, right? Remember, can I use otic products in the eye? No. Ophthalmic, can I use that in the ear? Yeah, absolutely, right. So again, those are, remember that key differentiator there is you cannot use otic stuff in the eye. Anyway, some special notes, and again, you can either use these otic antibiotics for things like otitis media. Oftentimes, they'll get used for things like otitis externa, as you'll see. And so, one thing to note with these drugs is, for one, neomycin. And again, Ciprodex, we mentioned, is very expensive, right? If you can get away with using something like a cortisporin, which was a combination of neomycin, polymyxin, and hydrocortisone, that's a much cheaper product that's out there, right? So again, interest of cost, you might want to prescribe that instead. However, some things to note. Ciprodex you can give to pretty much anyone, not really going to have any issues with that. One thing to note with the cortisporin, that neomycin, if you're going to have someone who has some dermatitis associated with this kind of local sort of allergic reaction, neomycin is the most likely one going to do that, right? And again, where else do you see neomycin commonly as far as like use, say for topical use? Yeah, Neosporin, right? That triple antibiotic. If you ever see that, a lot of times patients can't use that because the neomycin itself will cause some contact dermatitis as well, just like it could in the ear. They'll have to use something like a double antibiotic that will include like bacitracin and plus, polymyxin, right? They exclude the neomycin. So just know, neomycin most likely to cause hypersensitivity. Polymyxin B, not going to be good for patients who have like a ruptured TM or if they have tubes in place. The reason for that is that drug, if it gets into high enough concentrations where it can affect the hair cells in the cochlea, it can cause damage. Just like we mentioned, using things like polymyxin IV, very, very toxic to a number of organs. In this case, we're applying a very high concentration locally to the hair cells. That's no good, so that's not going to be recommended for them. And as I mentioned, Ciprodex is very expensive. Patients' insurance does not cover that. You have to have an alternative because they don't buy it. They're not going to use it, right? Sometimes, again, as I mentioned, we'll use things like ophthalmic ofloxacin, which is just another Cipro-like drug, another fluoroquinolone, and then we'll mix that with dexamethasone ophthalmic as well. Now, what's the downfall of using two separate drugs versus the one? Compliance, right? So again, fortunately, this is going to be a pretty short course, so it's not like it's going to be something they're going to take forever. However, compliance can be an issue. It's more volume you're having to instill in the ear, maybe less comfortable, but regardless, if they can afford it, they're going to be more likely to actually be compliant from that regard. Okay. Anyway, some antifungals you may run into from perspective. Ketoconazole is a good one. We mentioned we've talked about antifungals before, so I'm not going to belabor these points here, but it's an azole antifungal, so it's going to do things like affect CYP P450s in the fungus to prevent things like production of ergosterol. Again, that can affect us as well as far as causing CYP drug interactions. And the big thing you saw with the azole antifungals, which CYP enzyme did it affect? 3A4, right? If you had to guess a CYP enzyme that was being affected, you'd automatically guess 3A4, right? Because it affects so many different drugs that are out there. So again, educated guess would be CYP3A4 for any kind of these interactions. Of course, know the specifics on the different ones. So for instance, if you go back to looking at the drug Bactrim, sulfamethoxazole trimethoprim, anyone remember which CYP gets affected by that? 1A2 is actually going to be with it's more the fluoroquinolones. However, and we'll say 2C9. 2C9 is a big one, right? Because that's going to be affecting warfarin, and warfarin's a big deal for patients on that for AFib. They're on that for whatever needing for anticoagulation. That's a big thing because if you screw that up, if you give someone Bactrim and did not take into account their warfarin dose, guess what? INR is going to go through the roof. They're going to bleed out. No good. You don't want to cause that for your patient. Anywho, other things to remember to look for the azoles is they can cause QT prolongation. Again, not a problem by itself generally unless they have a prolonged QT at baseline. However, adding this on with other drugs can be problematic with that one. Okay. Nystatin is a very common one. So this is something you're going to see being used particularly for things like oral candidiasis, otherwise known as thrush, right? So you see it's used very frequently for thrush. So for instance, if I had someone who's taking like an inhaled corticosteroid, they had a thrush infection due to that, this could be used for that. The nice thing about nystatin is it's a very good antifungal, but it only works topically, right? So you're going to find that it does not get absorbed systemically, which is good from the standpoint if I need to just treat the thrush in the back of the throat, but I don't want to have all that systemic exposure. That's where I'm going to get a lot of use out of this, right? So this is nice, does not get absorbed. It's going to be able to break up those sterols in the fungal cell membrane, help to break that down. This is very good. We will sometimes use this prophylactically, right? So we'll use it before an infection for patients who are going to be more prone to developing thrush, right? So again, who is more likely to get fungal infections? Immunocompromised patients, right? So patients who have HIV/AIDS, right? They're going to have a very poor immune system, especially depending on how developed it is. They're more likely to get that thrush, right? Chemotherapy. If you find a patient who has thrush and doesn't really have one of these kind of compelling indications, it's a very odd sort of thing. You would definitely want to make note of that. But nystatin is very good for that. They can spit it out if they need to. no problem, but they swallow is not a problem because it does not get absorbed. No systemic effects because of that. Okay, that's a benefit. Sometimes you'll see this used as a topical product as well. Sometimes you have patients with things like ostomies and things like that. Sometimes you worry about getting like some local fungal infections. You can just apply this as like a paste or a powder right on top of that, and it's very good for that as well. Okay, so next up we have a couple antivirals. Again, I don't really have another good place to talk about antivirals in a large scale, so I would just kind of fit them in with this. We'll talk about hepatitis as far as viruses go later on. We'll talk about HIV later on as well. There's a whole infectious disease section that I do just for like STDs, HIV, hepatitis in the next semester, so we're not going to cover those here, but these are going to be kind of like your go-to sort of antivirals you're going to frequently. So several different ways that we can affect viruses, right? So we have to use different targets, just like instead of bacteria, we're shooting for specific targets like penicillin binding protein or the ribosomes. For the fungus, we're shooting for things like ergosterol. For this, we're going to be shooting for different targets as well. And again, these drugs are going to be specific for viruses. You can't use the antiviral for a bacterial infection, right? That doesn't mean if they have both going on at the same time, you can't utilize antibiotics plus antivirals, but one's not going to help treat the other. Several different ways, though, that we can affect this. So, for instance, with a lot of viruses, they will incorporate themselves into the human cell and then kind of release their particles. And especially with things like, HIV, they start to take over the host cell and produce new virus like that. And so there's different ways we can attack this. We're going to find that the main way we're going to be affecting the drugs we're talking about today is that they're specifically going to be inhibiting DNA synthesis and RNA synthesis of the virus, right? So if I block this, guess what? Can't make any new viral particles, okay? So this is the main way we're going to try to suppress these viruses. And again, what you're going to find is like, with antibiotics, I can eradicate a bacterial infection. For a lot of these infections, though, I cannot eradicate it, right? I'm not going to be able to completely get rid of that from the patient. However, I can suppress further reproduction of the virus. Okay, so I can hopefully, if they're, say for instance, you have a patient who's having, say, a herpes outbreak, I can help to blunt that outbreak and try to decrease the production of those viruses. Even though I can't get rid of it completely, I can at least help to decrease the symptoms of those breakouts. Okay. We're going to be talking about today. We're going to include herpes simplex. We're talking about varicella zoster, and then a little bit about cytomegalovirus. Cytomegalovirus you don't find too frequently unless you're dealing with like a really immunocompromised patient. So I mentioned like cancer patients, HIV patients. But herpes simplex, varicella zoster, you're going to find all over the place, right? This is very much more prevalent than you would see like a cytomegalovirus. Anyway, herpes simplex type 1. Where do you typically find type 1? The upper portions of the body. Type 2, typically going to find around the genitals. Does not mean you cannot have cross coverage there, but it does mean that's typically where we find it most frequently. Varicella zoster, obviously, it's our chickenpox and shingles. What's the best thing we could do to potentially prevent, say, for instance, like a varicella zoster infection? Immunization, right? So you can always do immunization. Certainly, you can potentially have patients who will develop their own immunity, right? So you're learning about that in micro, I imagine, right? Things like passive immunity, active immunity, right? So anyway, that's something you can develop immunity to. However, if we can give them the vaccine beforehand, hopefully we can prevent that infection from occurring in the first place, right? Dedicated anti-vaxxer, and you say no vaccines for my children and my patients, but can't do anything about that. We'll test you like we're going to use vaccines, so just be ready for that. Anyway, the big way we're going to be working to prevent RNA and DNA production for these viruses is basically by giving guanine analogs. Guanine, where does that get incorporated into? DNA, also RNA as well, right? So again, if I prevent the production of new DNA and RNA, because I'm going to basically put in these kind of false nucleotides, it's going to get incorporated into the viral DNA or potentially the RNA. These are going to act as what we call chain terminators. That basically means you cannot elongate any further off of this. They look enough like guanosine to get incorporated in, but then they can't extend anything further. You can't actually add any more nucleotides to this. Once they detect that there's enough damage being done to that DNA or that RNA, it says, okay, we're just going to get rid of it completely, and then hopefully prevent that virus from replicating and proliferating at that point, okay? Anyway, obviously you're not going to have to draw structures, but I just want to show you how you can see how these look very similar to what guanine would look like, how it can get incorporated and be fooled basically by, can fool the virus from that standpoint. You're going to find this also comes up when we're talking about cancer drugs. We have some cancer drugs that will do the same thing, but these are going to be more specific to viruses. The cancer drugs are going to be better all-purpose for human cells, okay? So what we see here, basically you can kind of divvy these up into kind of 3 different groups here. So I'm going to tell you why that is in just a second. So you kind of have your acyclovir and valacyclovir. What do you notice about the naming there? acyclovir is in both of them, right? Vir, if you see a VIR at the end of the name, typically it's an antiviral drug. Okay, so that's kind of a good rule of thumb. But we notice acyclovir is included in the name valacyclovir, so it should key you in that there's probably some relationship here, right? Pencyclovir and famcyclovir are also linked. They do not share that same naming convention. However, you have ganciclovir and then valganciclovir. Okay, so you guys remember the concept we talked about called prodrugs? Right, they're way better than the amateur drugs that we use normally. Right, what's a prodrug though? Yes, in its current state, it is inactive, right? But it has to be metabolized to get to the active form. So what's the purpose of doing that? Why would we ever do that? To avoid first pass effect, right? Or basically the first pass that happens is tricking the liver into doing, you know, the drug a favor. It says, hey, thanks for metabolizing me. Now I'm acyclovir. Now I can actually work on the virus itself, right? So valacyclovir doesn't really have much antiviral activity. It has to be converted over into the acyclovir, and then it can actually interact with the virus itself, right? Famcyclovir will get turned into pencyclovir, and then valganciclovir will be turned into ganciclovir, okay? So anyway, so looking at these, basically they lack the sugar moiety that a normal guanine would have, and so because of that, they cannot elongate any further along the DNA or the RNA, and that will help to prevent that, and then eventually cause breakdown of the virus itself. Anyway, what we're going to find is that acyclovir, valacyclovir, you can see the brand names right here. These are going to be good for herpes simplex and can also be used for varicella zoster, right? So if you have a patient has like a shingles outbreak, someone has an outbreak, say, of, you know, oral herpes or things like that, these are going to be the drugs you can help to use or to use for that, okay? Again, looking at the bioavailability, this makes sense because acyclovir, 22%. However, prodrug, valacyclovir, we can give that and get much higher levels off of that. So that can help us to limit maybe how often we have to give the drug and help to limit us, you know, maybe the total amount of drug you have to administer. So if you look at the doses between the two, you'd see you need a lot more acyclovir just based off the percentages, right? But again, when you're looking at the dosing, they've already taken this into account for that effect. Which one do you think is more expensive? Yeah, the Valtrex was more expensive. It was also the newer drug, right? So it had a patent for a longer period of time. And so it's one of those things. I know you guys were around like when Valtrex like first came out and all these commercials. I feel like it was on TV like all the time when I was a kid, and I was like, man. The only thing I remember though is like, remember, just because you don't see any active lesions does not mean you cannot spread herpes to your partner. And so I always remember that, right? So that's a good key point, good education point for your family, or for your family patients, I should say. Could be your family, I don't know. Everyone should be educated regardless of whether or not they're related to you. But for your patients, I should say, I treat all my patients like family. So there you go. Anyway, right. So again, these are going to be good for herpes, also going to be good for varicella zoster. Okay, those are the two main indications you're going to see with this. So that way, if they have things like, you know, herpetic stomatitis, right? So they're developing, you know, oral ulcerations from the herpes. This is good for utilization of that, right? It's going to help to kind of tamp down that reaction, help to hopefully get to, you know, healing those ulcerations faster than they would otherwise, right? Because again, am I going to clear someone of herpes when I give them acyclovir? No, right? That's never going to be able to get rid of it. So some of the things you're going to run into, though, are these drugs are not going to be without their side effects, as all drugs are. The big thing to remember with this is that you're going to see kind of three main sort of flavors of toxicity with acyclovir and valacyclovir. Biggest thing is that when you want to maintain good hydration, these drugs have the propensity to crystallize out within the renal tubule, okay? So again, the things that will help that to occur is that the drug's more concentrated. So how do you dilute the urine? You drink more water, right? So that way, if you're kind of flushing the kidneys out, that's going to help to keep the acyclovir in a low enough concentration where it should not crystallize out, right? It's called crystalluria when that happens, and basically what it can do is actually obstruct the nephron and cause some interstitial damage there. So you want to prevent that, okay? So that kind of makes sense. You actually see decreases in renal function secondary to this if this occurs, okay? So be careful with that. There's also going to be renal dose adjustment obviously needed for that if you're not able to process this through appropriately. Other big thing you can see is going to be things like CNS effects. So for some patients, especially those with poor renal function who cannot clear the drug, they can accumulate levels up, and that's where you can see things like tremor, delirium, and then seizures can also happen here as well. Okay, so be aware of that. Other big thing is this can cause bone marrow suppression, which is not good because who do we say is typically going to be more likely to be kind of affected by these type of viruses? Immunocompromised individuals, right? So again, that's one thing you want to be careful of. You're going to be watching, hopefully, their CBC anyway. We could see some further bone marrow suppression due to this. Why does that make sense, though? If you're thinking about why would this cause bone marrow suppression? So
because you're preventing the guanine replication, right? So I guess that's
You're absolutely right, right? Yeah, you're like 90% there, right? So again, think about fast dividing cells are the ones that are frequently undergoing mitosis. They're the ones frequently undergoing DNA replication, right? So again, it would be nice if these were completely selective for the viruses, but that's not the case. So what you find is that this would be having some bleed over effect. It would affect our white blood cells being produced in the marrow, right? Or other potential hematopoietic cells. If you prevent that DNA replication from occurring, guess what? You prevent the cells from replicating. So that's why you can end up seeing that. Now, it won't be as severe as it is for the virus effect, right? However, there is going to be a little bit of a bleed over there. You have to be careful of. So watch the CBC, look at their white counts, look at their hemoglobin, hematocrit, things like that to make sure they're actually able to still, make new cells as they need to, right? Again, for these drugs that affect things like DNA replication, like they're going to be affecting fast dividing cells most frequently. That's why you end up seeing like patients with cancer treatment, right? What's one of the first things that you notice about a cancer treated patient visually? They lose all their hair, right? And again, the hair is rapidly dividing. We're always producing new hair cells and things like that, right? So that's one of the things you see. The GI tract is another big one that gets hit as well. So again, these are things you can kind of think about. Now again, the key to treating viral infections is the sooner you get the drugs on board, the sooner you're going to get good effect, right? And in fact, there's some evidence to show that if you wait past 24 hours once symptoms show up, or past 48 hours, you end up seeing less and less effect of the drugs themselves, okay? So again, the sooner you get it on board, the sooner you're going to have good effects for your patient, more likely are to actually see some beneficial effects. And again, that's things like, relief of symptoms, clearing things like the oral ulcerations, things like that. That's a very good question. So we'll actually talk about that probably next semester when we get to it. So there is some kind of competing thoughts of whether you want to do things like basically breakout therapy, where basically you, as soon as the patient has an exacerbation, you would treat at that point, right? So again, once they start to develop symptoms, or if they have any kind of prodrome that like kind of the patient will know when they're about to get an outbreak, that would be a case where you want to go ahead and start using kind of this bolus therapy, this kind of pulse dose therapy. There is another camp that would say do chronic suppression therapy, where if I chronically have these drugs on board all the time, then potentially I could prevent an outbreak from occurring, right? So again, for some patients who have more frequent outbreaks, that might be better to be on that chronic suppression therapy. Obviously, viral resistance is still a concern. It can happen. Not as big a concern as you see with like the bacteria. However, the longer you're on a drug for, guess what? More toxicity you may experience, right? So these are also things you want to consider as well, right? So again, you may find some cases where one paradigm is better for one patient versus another, right? Good question though. And again, this will shorten the acute illness, but will not get rid of it completely. Okay, and again, earlier is going to be better for this. Pencyclovir and famciclovir have very similar mechanisms to acyclovir that we saw before. Sometimes you will use these in cases of resistant viruses that cannot be treated with acyclovir. Acyclovir and Valtrex, those are going to be the most common ones you're going to run into for treatment of varicella and for herpes. However, because they get used most often, guess what? Also most likely to develop resistance. So because of that, we have some of these backup agents that we can use as well. Okay, toxicity is going to be very similar to this. Excuse me. And also some of these are going to be available IV. Typically, when we're giving the IV form, which one do you think we give, the prodrug or just the regular drug? The regular drug. Why is that? Yeah, we're bypassing first pass anyway, right? So we don't have to worry about the liver tax at that point. So we can go ahead and just give them the parent drug itself. So for instance, you don't really see Valtrex IV, but certainly you see acyclovir IV that could be given, right? Other things you have to consider, other manifestations could be things like a herpes encephalitis, right, where you actually have like a CNS infection that can occur here. That's where you're going to be more switching over to like IV therapy, because you want to get really good high levels in the body and not worry about first pass, right? But for most outpatient kind of thing, that's where we're going to use oral therapy for the most part, okay? And then the last two here, we got things like valganciclovir and ganciclovir. Again, very similar mechanisms. However, this has a little bit expanded coverage, and that this will treat cytomegalovirus. The other group of patients you think about a lot is having a suppressed immune system, or transplant patients. And why did I say they're immunocompromised? We have to make them immunocompromised, right? We have to give them steroids and give them other drugs that are going to tamp down their immune system so they don't reject the organs that we're giving them. So again, sometimes you may find patients who will be on this maybe prophylactically, potentially, if they're really high risk for developing CMV, right? And again, valganciclovir, better bioavailability than ganciclovir. Other things to note here is that you're much more likely to see blood dyscrasias here, so things like neutropenia, thrombocytopenia. Again, we're kind of going up in scales of toxicity, where acyclovir is probably the best tolerated, up through ganciclovir being kind of the worst from a side effect perspective. So much more likely to see things like bone marrow suppression. That's why we like to reserve it for more resistant infections, or if we have something like a CMV that we need to treat there. Okay. And again, a lot of patients need to stop therapy just due to the side effects, right? So for instance, if you get them so neutropenic that they can't fight off any other infections, that can be a problem, right? Okay. One other one we'll talk about here is this is actually good timing, because guess what we're heading into right now? Flu season, absolutely. So is everyone going to get their flu shot? That should be a yes, I would hope, unless you have a strong contraindication, I would suggest you get it. Again, I don't make any money from the manufacturers for this stuff, but if they would like to sponsor me, I'm always open to negotiations. But anywho, oseltamivir or Tamiflu is going to be your go-to. I mean, we get like 55-gallon drums of this stuff practically, and just like tap it with the keg thing and just give it to all the kids as they come in the ER. Like, we get this stuff out like water, and it's unfortunate because it probably isn't all that useful and is just probably incurring a little bit more cost here. However, there are some very good use cases for this. Anyway, so this is going to be a drug that is used very frequently against influenza A and influenza B. Now, of course, you say, well, you know, I got my flu shot. I must be protected from the flu, right? Is that always the case? We'll talk about vaccinations later on, I think next semester. But one of the things to note with that is that when you get treated with the flu shot, anyone know how many strains of flu you're actually protected against? 4. It used to be 3, but nowadays the ones we give are called quadrivalent. They're for 4 strains. Are there a lot more than 4 strains of flu out there? Absolutely. Again, we try to predict, or people like at the CDC and whatnot, they try to predict what are the most likely strains to be present that year, to be prevalent. Do you think they're perfect? No, right? As humans, we're all fallible, and so sometimes they goof up, and sometimes the vaccine we get is going to be less effective than the one that might have been last year, right? Or maybe the one this year is going to be super effective. We have no idea, right? But typically flu season, you're thinking October to March. In some places it can range a little bit. Sometimes it goes a little long, sometimes it goes short. Just depends on several factors there. But however, Tamiflu is going to be used. Basically, it works against this viral neuraminidase, right? So basically what this does, it kind of prevents new viruses. When they are formed, they usually kind of bud off from the original one and they can go and infect other cells. This actually prevents it from occurring. So once it stunts that growth, it prevents the flu virus from actually being able to replicate there. The other big thing to note with this is, again, with all antivirals, the earlier you start therapy, the better off you're going to be. For most patients who are otherwise healthy, but say you come in, got flu-like symptoms, myalgias, fever, you know, runny nose, and you check them, you do a rapid flu swab, and they come back positive for flu A. If it's been more than 48 hours, chances are you're not going to get a whole lot of bang for your buck. At that point, the evidence shows that you don't really have any kind of much improvement in symptoms. Really supportive care is the best thing. You don't really shorten the duration of symptoms at that point. You need to get them in within the first 48 hours of symptom presentation, okay? So again, I could write a test question that says, hey, little Jimmy comes in, he's got all these symptoms, I test him for flu, comes back positive for flu A and flu B. You know, symptoms started, you know, 72 hours ago. And the question is, what would be the best treatment? In this case, maybe no treatment is going to be the best thing, right? So again, giving Tamiflu is not going to be shown to be all that effective. And they may say, well, you gave it to my other friend the other day when they came in to the urgent care, came into the ER. You're going to say, listen, the time frame just shows that we're not going to really get much bang for a buck. I'm just going to give you a drug that's going to cost you money that's not really going to do anything, right? So sometimes you can make that argument, and that will help to placate them a little bit. But there are some exceptions to that. There are some patients who are sick enough who may still get some benefit from this, right? So again, when you're thinking about patients who may have a impaired immune system or maybe not quite as strong as some other individuals, you think about the very young and the very old. So kids less than 2, we'll treat them past that 48-hour mark because they may still have some benefit. But guess what as well is that when those patients get sick, they tend to get much sicker than your run-of-the-mill, say, 16-year-old or 24-year-old, right? So because of that, we will go ahead and administer to them even if it's more than 48 hours. For the old, so greater than 65 years of age, we'll also administer to them as well. They likely have a host of comorbid conditions will also make this likely to be more effective, okay? In chronic conditions, diabetes, COPD, especially respiratory conditions, right? Those are the big ones that are going to make them a little bit more prone to having problems when they develop flu, right? And then again, immunosuppression, you know, if they have a history of cancer treatment, they're neutropenic, transplant patients, all those would benefit as well. And obviously, if they come in and they're sick as snot and they're getting intubated because of this, obviously you go ahead and just give it anyway. Because again, the question is like, well, you know, is there going to be any real negative any problems with giving it versus the potential benefits you could have. And the thing is it's nice that Tamiflu really doesn't have too much in regards to side effects, right? Acyclovir, other drugs like that, much more toxic than we see with Tamiflu. Most people don't have any issues with Tamiflu. However, we do know that if we overuse it, giving it too many people, resistance is becoming a problem. Okay, we're seeing more and more strains of flu A and flu B that are going to be resistant to the Tamiflu, and so that's going to be a problem, right? Now this is the oral only drug, so either we'll have like tablets, or I'm sorry, capsules we'll administer, we can have liquids we'll use as well, but watch out for renal dose adjustment, especially in those older patients.
Can you explain what Tamiflu, what the relation was with the neuraminidase?
Basically, it inhibits the activity of that enzyme. So it basically blocks the activity of neuraminidase, and it will prevent those new viruses from kind of budding off of the parent one and prevent it from replicating, essentially, right? When it's trying to undergo, I guess not mitosis necessarily because they're viruses, but when they undergo replication, they will prevent that from budding off, basically. Okay. Now this is kind of interesting. So if you look at the dosing recommendations, this comes from the CDC. And again, I'm not going to ask you specifically to dose this on a test by any means, but it's just good for at least your exposure. Again, if you see this, you can look to see kind of what the dosing recommendations are. Notice here that this is based off of weight breakdowns, right? So normally, if you have a kid very young, we just do like a 3 mg per kilo per dose twice daily. And then, however, once you get a little bit older, that's when they start to break them down these weight categories. Again, it doesn't really apply to any specific age, but based off these kind of wide-ranging brackets, that's what they recommend. Okay, I think I put the. I'm going on there, but usually 5 days is what they're going to be administered. So you get it twice daily for 5 days, and then hopefully that will shorten the duration of their symptoms. It doesn't necessarily make them improve overnight necessarily, but it can hopefully shorten it up a little bit. Okay, those are big things to note. Any questions on the ENT stuff? Okay, I'm going to keep going for a little bit if you guys are okay with that. Okay, so going into, let's talk about some anti-inflammatories. So we're getting away from the infectious disease component a little bit there, so everyone can breathe a sigh of relief. Okay. Kind of run-of-the-mill. These are going to be like gold standard. Like, you got to know these drugs, so you're going to use them all the time. Your patients use them all the time. These are good drugs to know about, right? A lot of these ones we're going to talk about are going to be over-the-counter products as well. And remember, patients like to self-medicate, okay? So because of that, you need to make sure you're asking questions about these drugs. You need to make sure, because some of them can actually be quite dangerous, right? Does anyone know how a drug goes from being prescription only to over-the-counter? What'd you say?
Make a illegal drug with it.
You can make an illegal drug with it? Okay, so that's maybe how something goes from over the counter to behind the counter, right? That's sort of, we'll talk about Sudafed in a little bit, but basically what happens is that you have a prescription product, and usually these drugs are prescription products for years and years and years, oftentimes far past when their patent expires and you can make generic drugs. But the drug companies or the manufacturers could go to the FDA and say, hey, we think this is a very safe drug. We think it is okay for patients to manage their own disease with in certain limited circumstances, and we feel this is okay to use, right? Because again, once you put it over the counter, any Tom, Dick, or Harry can go out and buy this stuff and use it to treat whatever they want, right? However, they're usually going to have a lot of directions on there to try to make sure that patients are going to be limited in that regard. So for instance, right, so say for instance I have GERD symptoms, right? So GERD symptoms, I'm having a lot of dyspepsia, I'm having a lot of problems whenever I'm eating. If I start to treat myself with an over-the-counter product like Zantac, most people have heard of Zantac, right? And I'm taking it for weeks and weeks and weeks, but man, this pain's just getting worse and worse and worse. I'm just going to keep taking more. It's fine. It's fine. The pain gets worse and worse and worse, and all of a sudden you have a perforation, right? The patient may not have known that a peptic ulcer. The problem with these things is when you're self-medicating, you may not know when to go in and find out if it's actually something worse. You actually need like more direct medical management for it, right? You need some kind of supervision. So usually you're going to find for a lot of over-the-counter products, they will say limit use to like 2 weeks. Or a certain short period of time, okay, to make sure that they're not masking something much more dangerous. They're just treating the symptoms of, rather than actually going through getting a diagnosis and getting management from you guys, right? So anyway, first one we'll talk about, and actually the other kind of interesting thing about that, interesting plus or minus, is the fact that a lot of very old drugs got grandfathered in, which basically means that they got basically put on this OTC status before we really had a good idea of like, good safety, safety data and things like that. They've just been used for so long. We're like, well, I guess they must be safe. Otherwise, why would they have it available, right? So they just put it over the counter. So for instance, salicylates, extremely deadly if you take the wrong amount, right? However, it's available at every single place you go. You can buy it over the counter. I can go to Costco and probably get, a metric ton of it for like $3, right? So just because it's over the counter does not mean they're safe drugs necessarily, right? So again, every drug can be a poison. All depends on the dose here. So we'll talk about that in a second. Anyway, salicylates, aspirin's the main one we're going to be talking about. If you're ever curious as to why it gets abbreviated ASA, it's due to the chemical name. You usually see that for a lot of drugs. I'll show you another example in a minute. But acetyl salicylic acid, or ASA, that's aspirin basically. Now, the mechanism of action for this drug, anyone know, like, what indications would I give aspirin for? Anyone know off the top of their head? Inflammation, like what kind of inflammation? It fell. I stubbed my toe, fell down. Okay, that's a good one. What else?
Recent stent placement.
Okay, so for stent placement, okay, so we'll talk about that indication in just a few minutes here. We'll talk about why that is going to be one. So we're going to see this is going to be used for certain hematologic uses, right? What else?
Cardiac issues.
Cardiac issues, right? So again, if we're trying to prevent MI, so that goes along with the stent placement. We'll talk about why that is in a second. What else? Headache, yeah, absolutely. Headache is probably the #1 thing people use aspirin for. Is just get a headache and then go ahead and start taking that, right? The reason for that is because this is going to be working against the enzyme cyclooxygenase. I know I've mentioned this enzyme before, especially when we talked about inflammation, like in physiology before. There's 2 main varieties of cyclooxygenase that are out there. Okay, there's going to be COX-1, so we abbreviate COX-1, and then COX-2, right? Now, when we talked about it, I don't know if I mentioned it, but do anyone know the difference between COX-1 and COX-2? COX-1 is going to be what we call a constitutive enzyme. And we know what constitutive means. It means it's made all the time, right? So again, you're always going to be expressing the COX-1 enzyme, right? It's going to be working on things like arachidonic acid coming from the cell wall, converting it into things like prostaglandins. It's going to convert it into things like thromboxanes. I'll show you this in a minute. COX-2, on the other hand, is what we call an inducible enzyme. This means under certain situations, it will become induced, it will increase in number to respond to a certain change. So for instance, if I stub my toe really hard and I have this nice inflamed toe now, that is due to the inducible actions of COX-2. Basically, they start to ramp up production, and now they start to produce all these new inflammatory cytokines, right? As we mentioned, leukotrienes, prostaglandins, other things, thromboxane, prostacyclins, all the things end up getting ramped up, okay? So we're going to talk about some of that selectivity in just a little bit, but in this case, we were saying this drug is non-selective, which means it's going to affect either one without really any kind of discretion there, right? It's going to affect COX-1 and COX-2. The other big thing to note here is that this is going to be a non-competitive and irreversible inhibitor, and this is specifically of platelets, okay? So I say irreversible, that basically means once it's there, once it blocks up that cyclooxygenase, guess what? An enzyme is done. It is not going to get regenerated until you start to produce new cyclooxygenase, okay? This is going to become important and why we use it for cardiac purposes, as we'll see here in just a moment. So just to give you an idea, what we can see with the effects of salicylates, right? So normally you think about like someone taking aspirin, say for prevention of, say, heart attack, right? How much are they taking? 81 milligrams, right? 81 milligrams. That doesn't sound like a lot, does it? What do you call that dose? The baby dose. You're just taking a baby dose of aspirin, right? Why do you call it a baby dose? Because 325 is a bigger, that is true. But 81 milligrams could be appropriate for an infant, right? So potentially, and we'll see why you don't give it to infants in a few minutes. But basically, we consider the baby aspirin, right? It's a very small dose. However, the nice thing about it is that it is an irreversible inhibitor. So this means that I can give you a small amount of aspirin every single day, and will go and eventually affect all of your platelets to the effect that where even if I were to miss a day, because that aspirin is an irreversible inhibitor, it still stays on those platelets. You still are going to see that effect there. The nice thing here is that it prevents platelets from activating, right? Remember we talked about hematology stuff and physiology, and how the platelets had to change conformation and they kind of grab onto each other, and that's how you form those platelet plugs. Well, again, that could be inappropriate if you, say, for instance, have a very, say, occluded coronary vessel, and all of a sudden you throw a bit of an embolus or something like that, and all those platelets bind onto it, and now you have a heart attack, right? So we go ahead and give things like aspirin for these irreversible platelet effects, and we're going to keep our platelets unactivated, basically, and make sure things can flow appropriately, right? Now, again, the double-edged sword of giving anything that has antiplatelet effects is what's the side effect of it? Bleeding, bruising, right? Normally, small doses like 81 milligrams a day, don't really see a ton of that unless you have like a really kind of at-risk sort of patient there. So again, that's good. We like the antiplatelet effects. That's what we're using it for, basically, for those patients who are, say, taking it after stent placement, right, to prevent the stents from occluding. Because again, anytime you put foreign material into the body wants to react to that. And again, if I have a piece like a piece of metal in a vessel, platelets want to bind to that. So aspirin can help with that. There are other drugs as well, but aspirin does a good job of that. Now, once you get to higher doses, we're going to find that salicylates have an antipyretic, which means what? They treat fever. They will bring your temperature down. And they also have analgesic effect. What does that mean? Good for pain, right? Doesn't mean it's good for GI issues, right? Just good for pain. So, right. So again, right now we're seeing that aspirin is unique in the fact that it has good antiplatelet activity due to the irreversible nature of its actions on cyclooxygenase. Also good antipyretic and analgesic. Again, higher doses even is where you're going to get more good anti-inflammatory activities, right? So this is why sometimes you'll see patients who have autoimmune disorders where they're kind of chronically overinflamed due to them reacting to their own body. You can see higher doses being used for its anti-inflammatory properties, okay? So again, when you're looking at aspirin, this is going to have good anti-inflammatory, analgesic, and antipyretic effects, okay? So again, these are the things you can use this drug for. Now, one of the other big side effects you're going to see here with, as we mentioned, the bleeding and the bruising being a potential adverse effect from aspirin. Another big thing you oftentimes will hear about is what we call tinnitus, where again, you're going to get this kind of like either ringing in the ear or this kind of muffled sort of sound that patients can experience. This is not always going to happen at like really high doses, although that's usually what you hear associated with is higher doses, above the therapeutic dose. Some patients actually get this at normal therapeutic doses, and aspirin is just not a very good drug for them. So that's one thing to note with that. And then actually, when you get to much higher doses than that, aspirin becomes super, super deadly. And in fact, when I talk about drugs from an overdose standpoint, I oftentimes talk about the sphincter scale, right? How tight you go, ooh, when you hear about a drug overdose. Aspirin, definitely one of those ones like a 9 or 10, right? It can be pretty bad if you have someone overdoses on aspirin. And in fact, what the problem is like a lot of people don't even understand sometimes that they're actually taking aspirin products. So is anyone familiar with like BC powder or Goodies powders? It's kind of a southern thing, but what are those? These are like little wax paper sachets that have powdered aspirin in it, right? So again, you can just put it into your drink, take it back, and then boom, you get your dose of aspirin. The idea is it's already kind of broken down to a powder form. It absorbs very well because you don't have like a tablet that has to be dissolved first. But some people, again, people with poor health literacy may not understand this, is that when they just know they take a BC powder for headaches, not realize that it actually has aspirin in it, right? So again, they're taking that for the headaches, and then maybe they have aspirin they take for their heart, actual baby aspirin. They don't equate those two as being the same drug. They can run into problems, right? I'll never forget, as one guy who he was had chronic angina. Every time he had chest pain, though, he would go ahead and take an aspirin, take a baby aspirin, right? Or take the 325 every time he had chest pain. And so one morning woke up, had chest pain, took an aspirin, right? Later on he had chest pain again, took another aspirin. Later on had some more chest pain, took an aspirin. Said, I should probably call paramedics to come take me to the hospital because they keep having chest pain. Paramedics get there, and what do they give him? You have more aspirin, right? So then he gets to the hospital, and the resident goes, hey, have you had any aspirin? He's like, I don't know. Guess what they give him? More aspirin. All of a sudden, he's like, man, my ears are really ringing. He's kind of hyperventilating. He's sweating. And you're like, we should probably check an aspirin level. And sure enough, it was like, pretty high. Having to treat him for an aspirin overdose on top of the, the chest pain he was experiencing there, right? So you got to be careful with this stuff, right? And again, because it's over the counter, people don't think about it as being, a potentially dangerous drug. Anyway. Again, contraindications, things like bleeding disorders. Obviously, this can increase the risk for bleeding. Pregnancy, we typically don't administer this. Maybe okay for some cases of preeclampsia, but we do not use it very frequently. The other big caveat with this one, and it's a good thing to know, is that you do not want to give this to children who are having a viral illness. Okay, now, can you look at a sick kid and automatically tell if he has a virus or not? Could be bacterial, could be viral, who knows, right? So again, typically we do not use this for kids less than 16. Okay, else we have a really good indication too. So for instance, we'll use aspirin for some of our cardiac kids over at Nemours. If you have a heart transplant or if you have any kind of major heart surgery, open heart surgery, typically you're going to be put on aspirin afterwards because you don't want the body to clot off. Those kids can get it because again, they're not having a viral illness, they're just having a cardiac issue. But they have the case of chickenpox, or if they develop influenza during flu season, guess what? They do not receive aspirin-based products. The reason for that is due to something called Ray's syndrome. Okay, anyone ever heard of Ray's syndrome? It's this fatty liver encephalopathy. And you'll see this on all the packaging for aspirin-containing products. We do not want to administer it to kids less than 16 because mortality can be very high, especially when you're not going to catch this, okay? Because a lot of times the symptoms can mask the illness that they had anyway, okay? So for instance, vomiting. Guess what? Sick kids like to vomit. Oftentimes they give no warning, and then your whole bedroom is covered in it. Not that I have any recent experience with this, but they get this progressive CNS damage. They develop this encephalopathy, hepatic injury, hypoglycemia. And again, many organs are going to take a hit from this. And because it is difficult to discover, especially if you don't understand and equate things like aspirin use in these kids, it can go on for a prolonged period of time before the kid really starts to crump. And then at that point, it's kind of not a whole lot you can do. Okay. And again, mimics the symptoms of things like, upper respiratory tract infections, influenza, etc. Okay. It kind of has these 5 stages. I'm not going to quiz you specific on the stages. I just want you to know that you associate Ray's with aspirin specifically. Again, this is a unique sort of combination I want you to think about. But again, it can develop, very severe disease can be, take time to manifest. And again, once you're kind of too late, you can't really do a whole lot for that child. And unfortunately, death happens quite frequently if not watched early. Anywho, the other thing here, why do you think I put Pepto-Bismol on this product here? And we know what the generic for Pepto-Bismol is? Called bismuth subsalicylate. Again, when do you use Pepto? What do you use Pepto for? Yeah, usually like stomach pains, like if you're having like some like GERD symptoms. Potentially, I don't know, my mom always gave me Pepto. It does not matter what I had growing up. She's like, here, take some Pepto. It's fine. Probably inappropriate now that I think back on it. And fortunately, I did not develop Ray's syndrome due to a viral illness that I had at the time, right? But anyway, that salicylate's a key component there, right? That can actually have an interaction. What's interesting, though, you can always spot someone based on a KUB whether or not they've had Pepto-Bismol recently, right? Because again, when you think about things that are radiopaque, what's one of the things you think of? Metals are a big one, right? So again, if you had someone that like some hardware, or say someone swallowed a nail or a battery or something, like metals tend to be radiopaque on the KUB. Well, guess what? What's the first thing I said in that name, the drug? Bismuth, right? So bismuth is a metal, right? So if you go look on your periodic table, you can find it there. Anyway, but you can see this like little punctate marks kind of all over the KUB, and that's typically going to be seen with the Pepto-Bismol. So if you ever see that, you can be like, hey, have you had any Pepto recently? And they'll be like, yeah, and your attending is going to go, wow, how'd you know that? And be like, it's based on the x-ray, right? So anyway, you can really try to give you guys the tips to try to impress people, okay? That's the main goal of medicine. Anyway, so indications, things we're going to give aspirin for. Again, if they have fever, right? We're going to administer this if they're having, minor aches and pains, headaches, stub your toe, anything like that. These are going to be good for. Things you want to note, again, because patients can self-treat, they need to make sure not to use this for too long. So if they're taking it for more than 10 days and their original symptoms are not getting any better, you need to get checked out. You need to figure out if something else is going on that could be much more serious, right? Now, when I say NSAIDs, anyone know what NSAIDs means? Non-steroidal anti-inflammatory drug, right? So again, NSAIDs, we'll talk about these in a minute, but they include what kind of drugs? Ibuprofen, naproxen. Those are two big over-the-counter ones. We'll talk about those here today. We'll talk about NSAIDs much later in like the rheumatology section later on. But do not take aspirin along with NSAIDs because you're going to find they have the same mechanism. And aspirin is technically considered an NSAID. You do not want to use these together because, again, you're going to see more risk for side effects. No real actual benefit in efficacy, right? Now, the one caveat I would say, if you had an older patient or someone who had a cardiac history and they were taking 81 milligrams of aspirin daily for cardiac protection, they want to take some ibuprofen on top of that. It's probably not going to be a big deal, especially for just kind of intermittent pain things. Because you are taking such a small amount of aspirin, it's not going to be the same as if you're taking, say, like a gram of it 4 times a day, okay? So, again, that would be one caveat to note with that. And again, if you're taking patients taking other anticoagulants, things like heparin, things like warfarin, this will increase their bleeding risk. So just be aware of that, okay? And again, does this mean that if I stop the aspirin, does my bleeding risk go down immediately? No. Yes. It does not. Why not? Irreversible, right? So I need to start to develop new platelets, right? And again, anyone remember the lifespan of a platelet? Right, so again, it's going to take some time in order to develop new platelets, and so it's going to be a while before you actually see all those anticoagulant effects go away, right? The antiplatelet effects, I should say, okay? That's all there is, well, I mean, that's all we're treating, basically. Huh? Okay, yeah, so to clarify for Tamiflu, it works on influenza A and B. If there are other ones that are out there, they're not clinically relevant to ARPA. Those are the ones we're mainly concerned about. When you test for flu, you're testing for flu A and flu B, basically. Now, under those broad categories of flu A and flu B, there can be multiple strains, right? So again, the thing with viruses is they like to mutate, right? So especially with the flu, they have all kinds of mutations that can develop. And it may depend on where in the world you're working at. It could depend on the time of year. It could depend on lots of things, right? So when you get the flu vaccine, there are only 4 types it's covering for: 2 flu A's and 2 flu B's. Before, they only covered for 3. It was 2 A's and a B. But you guys remember like the swine flu came through? Like that prompted them to add in that 4th strain. So now we went from a trivalent to quadrivalent. We cover 4 strains. Again, just because you get the flu shot does not mean that you are protected completely against the flu. You're only protected against those 4 strains. We'll talk more about vaccines later on, but that's basically what we're getting at with that. Okay. Any other questions? What with me so far? All right. So again, moving on. The next kind of NSAID we're going to talk about today is going to be ibuprofen or Motrin. I don't know why I switched the brand and generic. Regardless, just keep in mind though that like when you see Motrin out there, does that always refer to ibuprofen by itself? No, that's the thing with over-the-counter products is that you can find that they will want to put their name on everything they produce. So Motrin, because of that brand recognition, right? Just like if I have a cut and I want to put something on it, what do you call it? A Band-Aid, right? Band-Aid's a brand name. It's an adhesive bandage. But you think Band-Aid, right? If I stick something in my ear to clean out the wax, you should not stick Q-tips in your ear. I do it anyway. I'm just kidding. Yeah, you think Q-tip, right? So that's the thing where you're going to find that they want that brand recognition. And so when you say Tylenol, you need to be specific because when you say Tylenol, that could be referring to acetaminophen. It could be referring to acetaminophen plus diphenhydramine. It could be referring to all kinds of products. So again, this is why we like to use generics when possible. And like when you write in your notes, at least my advice is, if you say Motrin, I'm like, well, what kind of Motrin was it? Well, no, I didn't ask. You got to be specific, okay? Anywho, so again, you're going to find that with Motrin being an NSAID, it's also going to be working on COX-1 and COX-2. Again, there's no selectivity with that. It's going to work on either one. When we talk more about things like pain management or talking about things like rheumatologic conditions, we will talk about ones that are selective for COX-2. But for our purposes, we're just talking about kind of the general over-the-counter kind that a lot of your patients are going to be taking for cough and cold complaints, typical upper respiratory tract ENT stuff, right? So anyway, so this is working on COX-1 and 2. The main difference in activity here between this and aspirin is it is a reversible inhibitor, okay? Now, does this mean that it does not affect platelets? No. It does affect platelets. It's only when it's around those. So for instance, with something like ibuprofen, fairly short half-life. If I want to use that around the clock, I can give it, say, every 8 hours. I can give it every 6 hours, but it's a fairly short half-life. Because it is a reversible inhibitor, as soon as it gets processed through the liver and gets sent away, you're going to find that the platelet effect goes away as well. It's not like aspirin where those effects can stick around for a long period of time. So for instance, if I needed to send someone to, say, surgery and they had a dose of ibuprofen, say, 12 hours ago, I'm pretty well sure that I'm not too worried about bleeding risk because the ibuprofen should be out of the system by that point, right? Versus if they were taking aspirin every single day, I could stop giving them that aspirin, but 24 hours later, they're still going to have those effects, right? And we actually double-checked it, and I was remiss in my knowledge of platelet half-life, or platelet, what should I say, lifespan, 8 to 9 days, right? So again, it can take time before you start to really regenerate all those new platelets. Anywho, so this is going to be good for mild to moderate pain conditions, right? So again, if you have someone who, say, for instance, breaks an arm, is this going to be good to treat that pain necessarily? Say an obviously deformed fracture. Probably not. You're probably going to give them something a little stronger, but good for minor aches and pains, right? Again, this is going to be an antipyretic, so it's good for fever. It's going to be good as an anti-inflammatory. It's going to be good as an analgesic, okay? So this fits all three of those. We talked about aspirin as well. Yes, ma'am.
The last ortho clinic I was working at, there were a lot of opinions were going around and warning patients that if they wanted pain medication to take Tylenol instead of ibuprofen because there's some, I guess, evidence that's showing it's delaying bone healing now.
There's a,
actually,
yeah.
Or is it clinically significant, or is that still?
That's probably something that will depend on several factors, right? So it could depend on the dose of the ibuprofen they're taking, could depend on how often they're taking it, right? So they're taking it every 6 hours versus they take it every once in a while. There are some concerns, right? Because what you're going to find is by tamping down some of these inflammatory cytokines from being produced, right? Because it's affecting that cyclooxygenase, maybe potentially you could see that. I don't know if it's clinically relevant, however, but if you talk to like an orthopedic surgeon, they might be able to give you a little bit better idea of like who that might be more relevant to. But we will administer, say we have a kid who comes in with a fracture, we give them ibuprofen all the time, right? So, but again, maybe that's just like the ER person and me talking versus someone who like works specifically in ortho, you might have different concerns, right? So it just depends on the perspective, I suppose. But good question. Anyway, big things to worry about though. So again, this can go back to aspirin as well. All these things, same things can apply. The only real difference in side effects you're going to see here is that the bleeding risk is bigger with aspirin due to the irreversible nature of it. But other things you can see, by inhibiting the activities of cyclooxygenase, we inhibit the production of prostaglandins. Okay. Now in the GI tract, what do prostaglandins do for us? They help produce the gastric barrier, right? So again, all that nice, thick, bicarbonate-laden mucus that is surrounding your stomach that prevents it from eating itself, that is due to prostaglandins, right? It's also due to things like, acetylcholine on muscarinic receptors, but prostaglandins are the big one there. So if I give you something that inhibits the ability to produce prostaglandins, what does that do to that stomach barrier? Goes away. And then all that nice pepsin you're producing, all that nice acid you're producing is going to start to eat through the stomach lining. And this is why NSAIDs are the #1 cause for peptic ulcers. Okay, this and H. pylori are the two big things you're going to be looking for if you have someone who comes in with a peptic ulcer. Okay. So this is also a concern from asthma, but again, clinically, you'd find that people take things, NSAIDs like ibuprofen and naproxen much more frequently for anti-inflammatory analgesic purposes than aspirin is. Aspirin typically is going to be really more relegated to those, cardiac protection, things like that. And again, that's just kind of how time has gone on, but there are always some exceptions to that. Okay, so that's one big thing you want to worry about is the risk for gastric bleeding, gastric ulcers from that. Okay, other things, edema and fluid retention. Does anyone know why this could occur? Well, prostaglandins are also very important for another organ that helps us to regulate blood volume. Not the liver, the kidneys, right? Where do prostaglandins play a role in the kidneys? So here we go. I'm going to go back to my drawing. You guys asked for it. If you had just known the answer, it would have been all good. But okay, so imagine we have our afferent arteriole and our efferent arteriole, and here we have the glomerulus, right? And then we're going to go down to the renal tubule, okay? And again, blood is flowing in this direction. Okay, so one of the things you always hear about is that if you give a patient with kidney disease NSAIDs, you can decrease kidney function, and this is why, okay? So remember, what caused, say, constriction of the efferent arteriole? Angiotensin 2, right? Angiotensin 2 is good when you wanted to increase blood volume if blood pressure is too low. Remember, what caused afferent arteriole vasodilation? Prostaglandins, right? So that helps to keep that vessel open. If I decrease prostaglandin synthesis, what happens to the afferent arteriole? It's going to constrict, right? And then what happens to GFR? So again, I'm constricting down, and this is getting smaller. So say it's going to go like this now. What does that do to flow into the glomerulus? It goes down. GFR is going to go down, right? Everyone with me so far? So again, if I cause the afferent arteriole to constrict due to lack of prostaglandins, you're going to cause GFR to go down. Now, again, in most healthy individuals with good kidneys, this is a very minor effect, okay? Because we can compensate. We have the ability to compensate for that with other things. Remember, you know, we can have things like, you know, maybe decreasing norepinephrine synthesis, right? So maybe decreasing norepi will cause that to dilate and try to counteract that or something. Patients who have poor kidney function, they don't have as much reserve, and so this is going to affect them more. You can cause an acute decrease in kidney function in patients who have kidney disease, okay? Similarly, how do you think we get fluid retention and edema due to this? Well, if less blood is being filtered through the glomerulus, more of that fluid is going to be retained, right? If I can't pee it out, it's going to just stay in the body. So this can be a problem for patients who have issues getting rid of fluid, namely kidney patients. And who else might have problems getting rid of fluid? CHF patients, right? CHF patients have poor usually poor left ventricular function. They have a hard time pumping blood out through the body, and so they have a lot of it building up, say, on the venous side. So because of that, they typically have worsened fluid retention, and edema can develop from that, right? And again, very frequently, kidney disease and CHF go hand in hand a lot, hypertension, diabetes, and all the good stuff, right? We'll learn about that later, but that's why you need to be careful with this. So again, patient have poor kidney function, I probably don't want to use NSAIDs in them because I worry about decreases in kidney function acutely, and I worry about that fluid retention. Okay, make sense? So go back to your physiology, review that stuff, because this is why I hit that stuff so hard. Is so now you can understand. Well, when I start to change the system a little bit by giving you a drug, what effects is that going to cause? Okay, and again, it's not just think about the direct effects right there. It's the downstream effects you have to think about as well. If I affect the glomerulus, what does that do to blood volume? What is that going to do to my blood pressure? What is that going to do to things like, you know, fluid depositing out into the interstitial tissues? All those things are going to be linked back to this one specific instance where we're inhibiting cyclooxygenase, decreasing prostaglandin synthesis. Make sense? Okay, go back and review that, and it'll make more sense. Anyway, so those are the big things you're going to see. All right, so other things you're going to find is that this can also lead to diminished effects of certain other drugs. So for instance, if my kidneys are detecting that GFR has gone down due to the fact that I've now given an NSAID to cause afferent arteriolar constriction, what do the kidneys want to do to respond to that? So now the macula densa is like, hey, we don't have enough fluid here. We're not getting enough filtration going on. What are we going to kick off? It's going to release, starts with an R, renin, right? We're going to release renin. That's going to increasing levels of what? Ultimately what? Angiotensin 2, right? So angiotensin 2 is a big thing there. So what you actually end up finding is if I have someone, they're on a drug that is blocking the effects of angiotensin 2, I can start to counteract that because now the kidneys are going to try to produce more angiotensin 2 down the road, and that can diminish the effects of your drugs, right? So now NSAIDs can actually have more of an antihypertensive effect because now I have more Ang2 affecting the body, okay? So this is where you can actually see that this can worsen hypertension in some patients, not because the ibuprofen is causing the patient to become hypertensive, but because it's affecting the kidneys, releasing more renin, okay? That's stuff through. Other things, you need to be careful. Certain drugs will not be cleared from the body as well, because if I'm diminishing the amount of volume being filtered through the glomerulus, I may not be able to get rid of those drugs from the kidneys, right? And again, if you have normal, healthy kidneys, it's probably not a big deal. However, patients who have poor kidney function, you may find you tend to have, they're going to have an increased half-life, they're going to be holding on to them for longer, and this can lead to problems, right? So a very good example of this is the drug lithium, right? Is anyone familiar with the oldies band Nirvana, they had a song about this. I hate to say, I was listening to classic rock the other day, and Nirvana came on, and I was like, man, it's so old. Anyway, lithium. Anyone know what you use lithium for? Bipolar disorder. Again, makes sense thinking of the band. And so looking at that, lithium is completely cleared by the kidneys, right? It's a small ion, just like sodium is. If I give you a patient has poor kidney function, they're on lithium for bipolar disorder, and I give them an NSAID, you can actually decrease the amount of lithium making to the renal tubules. They can't get eliminated through the urine. You hold on to it for longer. Buildup of levels of lithium can be potentially deadly, especially up in the CNS and cause seizures, cause all kinds of issues, right? And so you got to be really careful of this. So be careful. That's why you look for those interaction reports. You look to make sure that if I'm adding on an NSAID, is that going to cause any problems? That's the other thing, though, is like ibuprofen. Where you can buy that from? Everywhere, right? You can go in any store you want and probably find some ibuprofen to buy. So because that's so ubiquitous, it's so available, that you need to make sure you let your patients know, hey, watch out if you're going to take an NSAID because it could affect this medication, cause the levels to go up, could cause all those different things. So be careful with that. You know what soda used to contain lithium? 7-Up, yeah. So cocaine for Coca-Cola and 7-Up had lithium. Anyway, sodas were way cooler back in the day, I gotta say. Right, other things, looking at effects with anticoagulants, obviously that's going to be a problem, especially with ibuprofen. Again, only when the drug is around, but causing antiplatelet effects just like aspirin would, but just in a reversible sort of manner there. Okay, so again, be careful with those patients who are taking anticoagulants. Other things. Now, has anyone ever heard of someone having, say, like an aspirin or like an NSAID-induced asthma attack? Yeah, so if you ever hear like an allergy to ibuprofen or something like that, sometimes it's linked back to these asthmatic patients. The reason for that is, and I apologize, I don't have this in a table already, but I'm just going to put it here. So if you think about production of, say, things like prostaglandins and leukotrienes, right, you start off with arachidonic acid, right? So let's say I start off with arachidonic acid here, right? And basically, it can split off into several different products, right? So we talked about like prostacyclins and thromboxanes. So imagine here, I have prostaglandins, right? And this is going to be cyclooxygenase on this this pathway, right? So again, this probably looks like a child is doing this, but you'll get the point, right? So cyclooxygenase is working in this pathway in order to cause prostaglandins to be synthesized, right? So what happens if I come through and say decrease the activity of cyclooxygenase? Well, I still have all that arachidonic acid that's being produced. I'm just going to be shunting it into these other pathways here, okay? One of the other pathways you're going to run into is called the leukotriene pathway, okay? Now, anyone know what leukotrienes are becoming very important? Allergic reactions, but also similarly, asthma, right? So remember, asthma, find out like IgE-mediated issues, but leukotrienes are a big player with asthma. So what can happen in some patients who are maybe more predisposed to this is you're going to find if you block cyclooxygenase activity, you will then shunt that arachidonic acid pathway over into forming more leukotrienes. Those patients who may be really susceptible to it then can develop an asthma attack. So if you ever hear about someone who have like an NSAID-induced asthma or an aspirin allergy or an ibuprofen allergy where they had an asthma attack, that's what that is. Okay, I don't know if I consider it strictly an allergy. It's more of a kind of a biochemical mechanism thing, but I would still put that on the allergy list, and I would say that patient should not get that drug anymore. Okay, now it doesn't affect every asthmatic patient. I can take ibuprofen. I don't have any problems, but I'm not as susceptible as maybe someone else was. Okay, so that's one of the things you have to be careful with. Other things you want to be careful of. We don't recommend usually giving NSAIDs in kids less than 6 months of age, unless you're doing it, you have a very specific indication or a really good reason to. And it's very rare that you need to do that. Basically, what can happen is, in some kids, again, if you go back and or you'll learn about this, looking at neonatal or actually fetal blood flow, right? So typically with a fetus, who's breathing for them? The mom, right? Their lungs are not really all that functioning that well, and so they have a whole circuit that is set up just for the fact that mom's going to be supplying them and then getting rid of waste products through the mom, right? So because of that, they have what they call a ductus arteriosus. You know what that does? It can shunt the blood basically from the arterial to the venous side, right? Oops. In some patients, you're going to find that if they have a congenital heart defect, they rely on that ductus arteriosus to stay open after birth to make sure they can mix blood effectively, right? So make sure they can mix that blood to at least keep them somewhat oxygenated. If I give them an NSAID, and again, the only thing keeping that ductus arteriosus open is prostaglandins, okay? So for some patients, if I were to give them an NSAID too early and I had not diagnosed them with a congenital heart defect, I did not know that they needed that PDA, that patent ductus arteriosus, and I closed it up, guess what? now they can run into some issues, okay? Because they're not going to be mixing blood like they should. So because of that, we don't give it in kids less than 6 months of age. However, there actually are some cases though where a kid will have a PDA. We need to close it, and guess what we can give to close it? Give them IV ibuprofen, and that can actually close it up for us. So there's surgical ways to do that, but this is actually a chemical way we can do that for some of our neonatal patients. So again, just be aware, just don't give it in kids less than 6 months of age unless you have a very good reason to, like you're treating a PDA with this drug to close it. Okay, make sense? Okay, and again, be careful if they have any kind of like high-risk GI history. You know, if they have a history of gastric ulcers, anything like that, you can be very careful giving them NSAIDs. There are other drugs we can give along with that. We'll talk about those later, but just again, be careful from that standpoint. Okay, other NSAIDs you'll run into, we'll talk much more about. There's a whole slew of prescription-only ones. We'll talk about that in pain management and rheumatology. The only other big one you want to be at least aware of for at least over-the-counter use is going to be Aleve or naproxen. That one actually has a pretty long half-life. So what's anyone know the tagline for Aleve? All day long, all day strong. Like, I guess you guys didn't watch as much TV as I did growing up, but regardless, usually only like one-time daily dose, and sometimes twice a day. So that's kind of the benefit to it, is if you give it less frequently, the compliance is a little bit better, right? So only difference there. Again, all the same side effects, all the same issues from at least contraindications and things like that to worry about as ibuprofen, because again, they're in the same class. Okay. The next one on this list is going to be Tylenol or acetaminophen. Anyone know what you abbreviate acetaminophen to? APAP, yeah, APAP actually comes from the chemical name. So if you look at acetyl para-aminophenol, you get APAP, that's where that comes from, right? So you ever see APAP, they're just referring to acetaminophen. Anyone know where the name Tylenol comes from? What'd you say? They did not make it up. They actually had a method in there. I didn't know this for the longest time, but if you look at this, Tylenol. Whoever came up with that, I have no idea, but this is that's where they got the name from. Okay. Huh? Yes, some very bored chemists, if I had to imagine. Anyway, this is not something that would be on your boards by any means, but you can impress your friends, at least to some small amount, if you have very boring friends. Anyway. Or if you have friends, yeah. Anyway, so I didn't hear that, so I'm just going to assume it was something very nice he said. But anyway, continuing on, the big difference with Tylenol is it doesn't really have the same activity as you see with the NSAIDs, right? We don't consider this an NSAID. We don't really know the full mechanism for how this drug works. We just know that it works. However, it's not going to fit into the same exact niche as you're going to see with things like ibuprofen and other NSAIDs. This is going to be good as an analgesic. This is going to be good as an antipyretic. But what do you notice I do not use this for? Anti-inflammatory actions, right? Because this has no good appreciable effect on COX-1 or COX-2, so this is not good as an anti-inflammatory, right? So again, if I have someone who say, were to trip and fall and they say hurt their knee, maybe something like an ibuprofen is better for that because they're having a lot of inflammation going on there, right? Versus they're just having, say, like a headache, maybe Tylenol is better for that person, okay? Not to say you can't use them in either situation, but you're more likely to get bang for your buck if you have a good inflammatory process going. Something like an NSAID is going to be better for that, right? Okay, Tylenol still is pretty good as an analgesic, good as an antipyretic. As far as side effects go, very well tolerated. This is again why we like to use it so frequently, because it's a very good, safe drug for the most part. However, with one big organ toxicity you have to be careful of. Liver damage, right? So again, I'm not going to bore you with the whole biochemical pathway for why that occurs, but suffice it to say is your body can handle acetaminophen to a certain amount, right? And at some point, you're going to exhaust some of these metabolic pathways and start to produce a byproduct, right? It's called NAPK if anyone's interested, but basically it forms this toxic byproduct that can cause all kinds of liver damage. It can actually spill over and cause cardiac damage. It can cause kidney damage. Very, very bad if you have someone who has a pretty strong overdose with that stuff. So, but the problem is not with these patients who necessarily say they just take one single overdose of it, right? So the more dangerous ones are typically people who are self-treating, who don't understand that there is a limit to how much they can take, right? Because they take a little bit of Tylenol and it works okay. Well, then more must be better, right? So they keep taking it over and over again, taking more throughout the day. Maybe they're taking like 8 times a day. And that's where you can see that you get this very slow, festering sort of chronic toxicity. It can be pretty, it can sneak up on you.
So maybe for chronic pain management, when they have like Norco.
What is Norco? Yeah, so it's hydrocodone, so it's an opioid plus acetaminophen. Okay, what about it?
So like what would happen if they're like on chronic pain management?
It's a good question. So if they're, say you're chronically managing someone's pain, the one thing I would tell you is that that is not a good drug for chronic pain, as in 24-hour sort of relief there, right? So we don't use Tylenol for that standpoint. We use it for what we call breakthrough pain. So it's good for, say, for instance, and we'll talk about this in pain management, but typically you try to use two modalities. One is a nice controller sort of medication. That's where OxyContin comes into play because it's a long-acting medication. Well, they market it as long-acting and not quite as long-acting as we actually think. Another topic altogether. But anyway, actually Purdue Pharma's like starting to get looked at for some of the trouble there with their marketing. But anyway, you're going to find that they usually on like a long-term medication is good for control of their pain, and then for breakthrough, say for instance, they get up and they walk around and that exacerbates their pain. That's where things like Norco or short-acting medications can be good, right? Because they can, or if you have like a very short term, say like post-operative period, you just need pain medication for a few days, something like that. This is going to be better for that. Okay, but they run into the same problems. They can run into issues where they're taking so much of the stuff, especially if they start to self-medicate, that they can run well and above that 4-gram amount. And again, 4 grams, there's nothing magical about that. It's just what we know for most patients. Once they get above that, that's where you're more likely to see that liver damage. But there's some patients who have liver damage already. They do chronic drinkers or hepatitis, and guess what? They have a much lower threshold. They may only be able to handle 3 grams a day. Okay, but they can hit those issues there. The other thing is if I gave someone, say, a prescription for Norco or Percocet or something that includes acetaminophen, that 4 grams doesn't just apply to the over-the-counter stuff they buy at the store. That applies to all Tylenol sources together, right? So again, if you give them a prescription for Norco or Percocet or something like that, and they're taking it home and they don't realize that that has acetaminophen in it, because maybe their bottle just says APAP. Who knows what APAP is, right? If you had no literacy with that stuff, then they would start to take Tylenol on top of that, and guess what? That's when you can really get yourself into some trouble too. So you can be really, really careful. Make sure you're considering all sources of Tylenol and educate them. Do not take Tylenol on top of this because you run into some issues. Okay, maybe ibuprofen might be a good adjuvant, something you use additionally to that, but more Tylenol is not good. Okay, make sense? Very careful with this stuff. It can be quite deadly. This isn't like a 9 on the sphincter scale like with the aspirin, right? This can be a very scary patient, but this can be very bad if not caught and treated aggressively pretty early on. So just be careful with that. Okay. So again, be careful, especially chronic drinkers or anyone with a kind of chronic liver disease. They tend to be more susceptible to the damages of Tylenol. So then oftentimes we'll recommend a lower max dose for them. So maybe something like 3 grams a day or something. Try to prevent that from developing any issues there. Okay. Really no good contraindications for this product. So again, a lot of people can receive this. Very safe for the most part. Another nice thing with this one is not only is it available orally, but now we actually have an IV formulation that we can use, which is very good. There's actually some really good evidence to show that if you give this even as a single dose in the post-operative period, you decrease the total amount of opioids people need to take. And again, the less opioids you have to give them, the sooner you can get them out of the hospital and back home, right? The recovery ends up being a lot faster due to that.
Isn't there an issue giving Tylenol to kids for fevers?
There's an issue with giving Tylenol to kids for fevers.
Side effect or
That could be the Ray syndrome with aspirin, but I'm not. We give it all the time, right? So again, Tylenol is another one. So basically, if you go to the ER and you look at our vats of drugs, we have like a big one for Zofran in the winter times. We have a big one for Tamiflu, and then Tylenol, ibuprofen are probably the other two. If you were to look at our kegs of drugs, we don't really have kegs, but just kidding. We go through a lot of that stuff though. But yeah, there's no big issues. It's a very safe drug. We give it to kids of all ages for sure. If you see something specific, you may bring it to me, and I can see if it's like a unique circumstance or something like that. That'd be good to know. Also, rectal formulations are available as well, so it's nice to give us a suppository.
So Tylenol IV reduces the need for opioids in the hospital setting?
Yeah, like post-operative, right? So if you send someone to surgery, and again, I think the studies were mostly like with like ortho procedures and things like total knees and hip replacements and things like that. Just even a single dose of IV Tylenol decreased the total amount of opioids they needed. So yeah, so it's pretty good. And again, it's obviously more expensive, but they try to use it all the time.
Question, but PO or IV?
IV, as well as I meant to say. Yeah, so again, I mentioned IV forms now available, so you'd only be using it in the hospital anyway. Yep. Anyway. Very good drug. But if I asked a test question and I said a patient were to say break their arm, something like that, and they're having a lot of inflammation where they had the break, I asked what drug would be good for dealing with that inflammation. Tylenol would obviously not be the right answer because, again, it's not an anti-inflammatory. It may help with the pain, but again, it's working more centrally. It's really working from the CNS down because, again, for pain to be transmitted, it has to go from the site wherever it's occurring through the spinal cord up to the CNS. So if I can do anything centrally, and again, it's where a lot of our opioids are working, then you can help to blunt that pain. So it can work as an analgesic, just not as an anti-inflammatory. Okay? So we have our antihistamines. Antihistamines, what do you think they do? block the activity of histamine, right? So again, histamine is going to be a big player as far as from an allergic standpoint, right? So again, if you have things like mast cell degranulation in response to, say, like an allergic reaction, histamine is a big component there, right? So you're going to see this causes a lot of physiologic effects. I'll show you a table in a second here. Typically, when you think about having like an allergic reaction, so imagine I pricked you with something that you were allergic to, you typically get this kind of triple response, right? The redness typically caused by vasodilation, right? So again, vasodilation is going to cause more blood flow to the area to make it more red. This makes sense if you're looking at someone with an anaphylactic reaction. What happens to their blood pressure? They get very hypotensive, right? So if you're familiar with anaphylaxis, you'll see they get very hypotensive. That's all due to histamine for the most part, causing vasodilation. Okay, so that's one thing it does. You'll see the edema that will form due to that. So again, it can increase the capillary permeability. So you have more of that water, that fluid leaking out from the vessels that is now being brought in more copious amounts through the vasodilation. And then you normally get this flare that occurs here where you can have basically this kind of surrounding vasodilation that can occur as a kind of a reflex arc here, right? So that's where you see that redness, wheal, and flare that occurs within an allergic sort of local reaction. Now, histamine, you're going to find, has two primary receptors that we're going to talk about. There's also a third one, but we don't really deal with it too frequently from a clinical standpoint. H1 are typically where you're going to see a lot of the vasodilatory sort of effects. It's where you're also going to see a lot of the centrally acting sort of effects. So when you think about allergic reactions or like seasonal allergies and things like that, you're thinking H1 receptors, okay? When I talk about H1 blockers, that's what we're talking about today. Now, H2 is going to primarily be found in the GI tract. So when I talk about H2 blockers, those are the things like Zantac you're going to be using for GERD symptoms, okay? So we'll talk about that in the GI section later on. Really, we're focusing on H1 blockers at this point, okay? But again, you can see some of the things that pop up from this. So like primarily when you see something like H1 being affected due to an allergic reaction, TPR goes down, the total peripheral resistance. They get very hypotensive. Other things you can see things like increases in heart rates. They get tachycardic associated with that. Other big things to note here is you're going to find bronchial smooth muscle contraction. Why is that a problem with an allergic reaction? It impinges the airway, right? So then I cannot oxygenate from squeezing down all that smooth muscle, right? So that's why very frequently you can give something like, beta-2 agonists to cause smooth muscle relaxation, right? It's another thing you may see a lot for treatment of anaphylaxis. Or epinephrine potentially could be causing beta-2 activation, right? It's another big drug used for that. But histamine is one of the big components with that, right? So again, we're going to see antihistamines being getting a lot of utility here. But so basically, like I mentioned, we're going to see a lot of increased post-capillary permeability. That's where you see a lot of the edema that can develop from that. We're going to see more mucus secretion. So again, that includes nasally, includes in the respiratory tract, the GI tract. Again, when you think about seasonal allergies, what are some of the symptoms you run into? Rhinorrhea, right? You're going to see a lot of rhinorrhea associated with that. A lot of runny noses and whatnot. Some increase in smooth muscle tone for certain areas. And actually, in some cases, you may find some nerve endings being stimulated, whereas like itching and things like that can come about from that. And then the bronchoconstriction, obviously that being one of the more life-threatening sort of aspects of it. H2, just know that this is going to be really responsible for increasing gastric acid secretion. We're not going to talk about the drugs that affect this quite so much today, but in the GI section, we'll know that it will come up later on. Okay, so again, looking at the peripheral effects, if I were to give an antagonist, so an H1 receptor antagonist, what's actually going to happen here is it's going to help to block smooth muscle contraction. So this is not so much that we care from the GI standpoint, but from the bronchial muscle, that's good, right? We want to cause dilation for those muscles there so that we can oxygenate a little better. It's going to help to decrease the vasodilation, so this can help to prevent further hypotension due to histamine being released. It can help to decrease things like, the hives, itching, and all of that associated with those allergic reactions. Okay, so very good for treatment of allergic reactions, whether it be seasonal allergies, pet dander, peanuts, anything like that you have an allergy to. Histamine blockers can be really good for helping to decrease a lot of those symptoms. Looking at CNS effects, so this is important to note because we're going to talk about one big delineation between H1 blockers. We're going to talk about the first generations, we're going to talk about the second generations. The first generations typically have a lot more central side effects. When I say that, I mean things affecting the CNS. Okay, that is because they can cross the blood-brain barrier. The big difference between the first generation and the second generation H1 blockers is that the second generation cannot cross the blood-brain barrier. They cannot cross the blood-brain barrier. Guess what? They do not cause central side effects. It's a key point there, right? I'll show you a table in just a minute, and we'll look at the differences and side effects between them. But imagine, and again, our prototypical sort of H1 blocker that gets used most frequently is, anyone know? Benadryl, right? So diphenhydramine, it's an over-the-counter product. You see it used all the time, right? We have IV products that are available. POs used most frequently, even some oral topical products, but it's used very frequently. When you take Benadryl, what happens to your level of arousal? As far as like being awake or asleep, not the other kind. Right? You're the exception. I want to talk to you right now. We'll come back to you in a second. What do you find? You get drowsy, you get sleepy, right? And again, that is due to those H1 blocking effects as being causing sedation from this central standpoint. Now, that's not always the case. We especially see this in kids and in certain unique individuals, but they tend to have what we call a paradoxical reaction, where you can actually have a lot of excitation associated with it. That is more rare. Most people tend to get very sleepy when they take some of these H1 blockers. But again, this is only the first generation ones because they can get across the blood-brain barrier, okay? Oftentimes, this can be not necessarily a side effect, but it can be utilized as an actual therapeutic effect. So if you get Unisom from the pharmacy, it's an over-the-counter product. It's just doxylamine. It's another one we'll talk about. It's an H1 blocker, but we use it for its or basically for its CNS depressant sort of effects. Now, this can be additive, especially with other CNS depressants. So if I'm going to take this along with a benzo, or if I drink a bunch of alcohol with Benadryl, the patient's going to get that synergistic activity, and they're going to be knocked out even harder than would be just a drug by itself. Okay, so be aware of that. We especially see some excitation overdose. Actually, had a really good, it's a very case I just had the other day at the hospital. They had a kid who was up in the ICU, and he was very violent. He was fighting off the nurses and fighting with the family, and they just needed to get some drugs on board, what we call chemical restraints, where basically we're giving them sedatives to try to chill him out, so he's not a danger to himself or others, right? But he was in there due to an overdose on antihistamines. So again, this is something that can be a common drug of abuse due to the fact that it's everywhere. You can find Benadryl anywhere. You can get doxylamine anywhere. So because of that, they'd overdose on some of that, and they get very, very agitated to the point that they can develop seizures. They get very violent. And just to give you an example, the drug Ativan, anyone familiar with the drug Ativan? It's got benzodiazepine. It's a GABA. Basically works GABA to work better. Remember, GABA we said is what? The major inhibitory neurotransmitter, basically the brakes on the system, right? So when you have a seizure, which again is just your neurons firing too frequently, we give you Ativan, and that will slow everything down and will shut down that seizure, right? Now, a normal adult dose of Ativan that I give to a patient who's seizing, 2 milligrams, okay? This patient had already gotten 7 milligrams and was still awake and fighting. They get very, very agitated when they're on antihistamines like this. I had one patient who had went to a party, had overdosed on a whole bunch of, anyone ever heard of like doing triple C's? It's good, you guys are not, I heard one snicker, so maybe you know. It stands for Coricidin cough and cold. It's a common cough and cold product that has chlorpheniramine, which is another antihistamine in it. This guy had done like 3, you know, like when you pull out from a pill package and it has little blister packs. You can like punch out the things, they call those plates. He did 3 plates of this stuff, okay? So way too much. He got 14 milligrams of Ativan. So again, 7 times the normal dose to stop a seizure in an adult patient, and he was just barely asleep. Like he was still sitting there just fasciculating all over. It was bizarre. I was just like, holy cow, I would be dead on the floor if I got 14 of IV Ativan. This kid was just barely asleep, right? Just taking a little snooze. So be very careful, especially seeing these in overdose. And again, kids get into this, and they oftentimes have more time than wisdom, and so they get into some very dangerous situations with these drugs. So be careful with these in overdose. Again, first generation only is going to be the big thing here. Second generation, I mentioned almost no sedation because they don't get into the brain. They can't really cause these sedative sort of effects here, right? Anyone know a good example of the second generation? I'll show you a table in a second. Claritin's a good one, right? So Claritin, otherwise known as loratadine. Allegro, which is fexofenadine, and then there's a third one. We'll talk about Xyzal. Actually, Xyzal's kind of, I guess there's more than 3. The big 3, though, are the loratadine or Claritin, you have fexofenadine, Allegro, and there's Zyrtec or cetirizine. Again, I'll show you these in just a second on the table here. But those don't cause as much sedation because they just don't get across the brain there, right? Some other effects you're going to have, you find that a lot of these first generation antihistamines also work centrally. They have a lot of anti-muscarinic effects, right? Remember muscarinic receptors? They get activated by what? Muscarinic acetylcholine, right? Remember that's part of the parasympathetic nervous system, right? So these are going to be drugs that are going to be affecting the parasympathetic nervous system, if they have these strong anticholinergic effects. I'll show you some examples here in a second, but some of the benefits you see with that is they can help with things like motion sickness, right? So when you think about patients with like vertigo and things like that, oftentimes you're giving them drugs that kind of fit into this category due to the antimuscarinic effects, okay? Also going to have some good antiserotonergic effects. That one we're not going to worry too much about, but again, notice it's antiemetic and has antimuscarinic effects, okay? Which is good. So imagine if you're having seasonal allergies, right? You have a lot of rhinorrhea, your nose is just running like a faucet. Not only is it good that I give you an antihistamine to block the effects of that histamine from the allergic component, but I also give you an antimuscarinic. And what do we say the antimuscarinics would do to secretions? They decrease them, right? Because again, we talked about the dumbbells, right? Talking about dumbbells as being the activities of acetylcholine on muscarinic receptors. We also talked about the anti-effects, right? Did I give you the mnemonic for that? So that's where we talked about mad as a hatter, dry as a bone, which is what we're talking about there, blind as a bat, red as a beet. I didn't talk about that? Okay, so let me go with the antimuscarinic effects real quickly. This is a good mnemonic to remember for your purposes. Again, I know you had faith in me in completing this lecture today, but I might not be able to. But this is a good point just to know. So these are antimuscarinic effects you see with any of these drugs here we're going to talk about today, right? Especially the first generation drugs. So you're going to be blind as a bat, because remember, what do we say acetylcholine does to muscarinic receptors in the eye? Meiosis or mydriasis? Typically, acetylcholine causes meiosis. When I say blind as a bat, they typically get very mydriatic, so their pupils will dilate. Again, this is the anti-effect, right? So again, this is not the dumbbells. Remember, the dumbbells in was the meiosis. This is the opposite effect, right? So we're going to get mydriasis. They oftentimes can't accommodate, so they'll complain of blurry vision. We'll talk about that in ophthalmology, right? Because we'll give drugs that are antimuscarinic to try to dilate the eye. They're going to be dry as a bone. So they're going to have no secretions. They can get constipated. They develop urinary retention. Very, very dry, complain of dry mouth, dry eyes, dry nose, right? Due to the fact they have less secretions to do that, okay? They get red as a beet. This is going to be due to some of the vasodilatory sort of effects you see with that, so they can get a little flush. They're going to be, what's the other one? So they do get mad as a hatter. That goes back to the altered mental status effects we talked about. That excitation, right, to where even 14 milligrams of Ativan wouldn't shut some of these kids down. That's the mad as a hatter component to it. Anyone know where mad as a hatter comes from? Where? Mercury toxicity, right? Some of the filters, they used to get a lot of mercury in their system. Anyway, let's not talk about mercury toxicity. Right, so anyway, so we have hot as Hades as with the other ones, right? So they get very hyperthermic with the anticholinergic effects.
What was that?
Hot as Hades, hot as a match, hot as a hair. They use lots of different ones.
They also like sweat a lot since vasodilation.
So that's the thing. So they get hyperthermic, but they're still typically pretty dry, right? So they may get to a point where they're hyperthermic enough to where they kind of overcome that, just the body needs to cool down. But typically due to the decrease in secretions, they will be pretty dry, okay? And so again, I can sometimes, because oftentimes the patients who overdose like on anticholinergic, they look just like someone who overdosed on cocaine. The way I tell the difference is a cocaine person who's hyperthermic, they sweat like crazy. Someone who's on anticholinergic, they're typically bone dry, right? That's one way I can differentiate that. Question, yes?
What was the last semester? Did you teach us like the days of the week?
That was the nicotinic effects
Oh, okay.
of acetylcholine, right? So the nicotinic effects, the muscarinic or dumbbells. This is the anti-muscarinic effects. So again, blind as a bat.
That's my advice.
Blind as a bat is mydriasis. You're see with that. You're gonna be mad as a hatter. So you're gonna have altered mental status. Be dry as a bone. Hot as a match. Red as a beet. The other thing, what does it do to the heart? Anyone know? Remember, we talked bradycardia. You're going to see tachycardia seen with that, right? That's why I give atropine, which is an antimuscarinic drug, to increase heart rate, okay? It's not important for our purposes today, but when we run across atropine again, that's why we give that. So again, it will cause the heart rate to go up pretty significantly.
So I want to make sure.
Yeah.
Anticholinergic overdoses, or
This is just for any kind of antimuscarinic drug. Those are the effects you would expect to see from that, okay? Yes, ma'am. They get tachycardic with an anticholinergic. Right, because basically you're blocking. Because normally, if you think about the vagal nerve, normally when you're releasing acetylcholine on the muscarinic receptors in the heart, it slows it down. This is the opposite effect, so you end up seeing tachycardia. Okay, so again, this is basically the opposite of the dumbbells. If you had to think about that, but that's the mnemonic we use very frequently to remember anticholinergic effects. Everyone with me? Fortunately, this will be online for your review later if you have any questions. But All right, so we mentioned antiemetic action. So again, a lot of these drugs tend to be very good antiemetics. And kind of the other nice thing is that they're sick as the dog and they're throwing up. Like, you know, they probably want to nap anyway. So some of these drugs being very sedating can kind of be helpful with that. So I remember there's a drug called promethazine or Phenergan. This is before I was in pharmacy school, and so I did not realize this was illegal. But my aunt, who I was living with at the time, I was very sick. I was just nauseous, and I just felt like just total garbage. And she's like, "Here, take one of these." And I said, "What's this?" And she goes, "Oh, it's Phenergan." And I said, "Okay, whatever." And so I took it, and boy, I fell asleep for probably like 14 hours. It was the best sleep I ever had. I was like a corpse. But when I woke up, I wasn't nauseous, and I was dry as all get out. So I drank about a gallon of water after that because my mouth was just like, that really nice. Yeah, it's no good. So anyway, but again, very sedating, very good antiemetic sort of action. So we'll oftentimes give this, especially as maybe like a second line agent for to cause some antiemetic sort of actions there. Okay, and again, talk about drawing things up. So again, most indications we're going to use for these H1 blockers is going to be for allergic reactions. We use it for things like motion sickness. And remember, motion sickness is more of a centrally mediated sort of phenomenon, so that would preclude use of the second generation agents. I only want to use first generation for that. Okay. OTC sleep remedies, so again, the first generation thing. And I mentioned as an adjuvant role in anaphylaxis. When I say adjuvant, anyone know what that means? Second, it helps out the system, right? So again, primarily, if I'm going to have someone with like true anaphylaxis, the drug's going to save their life, epinephrine. If I give antihistamines as well to help that work even better, try to block some of those effects there, okay? So adverse effects, sedation. Well, I just said we were going to use it for that. But again, it just depends on what the purpose is, right? So again, if I have someone who, say, is a construction worker and manages one of these massive cranes and moves stuff around, do I want to give them having seasonal allergies? I want to give them an antihistamine first generation? No, because they're going to be sleepy and they might conk someone on the head with a big beam or something. Don't want to do that. Other things, GI disturbances. Typically, these being antimuscarinic will slow down the GI tract and will cause constipation potentially. So again, that is one of the things you want to be careful of, at least from a GI standpoint. Okay. I talked about antimuscarinic effects causing dry mouth, urinary retention. So again, if you had someone who already had urinary retention issues, like maybe they had benign prostatic hyperplasia, that could be potentially worsening that. And I mentioned the blurred vision already. Okay. Now, if you were using some of this stuff topically, like there's like a Benadryl topical preparation, you may see some dermatitis, but again, that's not really specific to any of these drugs. The table. Oh, yes, ma'am.
Can you get like high blood pressure from the too?
Not typically. I wouldn't normally associate hypertension as being an effect from these drugs. I mean, if you got tachycardic enough, I could see that increasing the blood pressure, but it's not normally, like if you take a normal dose of Benadryl, like you're not going to see your heart rate like jump up into the hundreds, But if I gave like a big IV dose very quickly, or if I was giving, maybe multiple doses very close together, that's where you can see more of those issues there, right? So it just depends on the clinical situation you run into. I mean, by the time they get to be some of my patients, like from the tox standpoint, they've taken a huge amount and they get very, very tachycardic, and very typically they are hypertensive along with that. But that's not like a normal thing you would see for like most patients taking like 25 of Benadryl or something, right? Anywho, so again, your first generation agents are going to be here. This includes your chlorpheniramine, which is normally you find like in cortisone, cough and cold, or like chlortrimetin. Again, most of these are going to be over-the-counter products, which is nice. One exception to that would be like hydroxyzine, otherwise known as Atarax. That is sometimes used as an anti-anxiety drug, good anti-allergy drug, but we don't use that as an over-the-counter product. It's not available that way. But things like Dramamine, diphenhydramine, this is far and away the most common one you'll probably run into in your clinical life. Promethazine is another prescription one only. Again, Phenergan, very, very sedating. I'm not going to have you memorize specifically the sedative effects versus antiemetic effects, but just know that typically when you see more of the anticholinergic effects, you tend to see more antiemetic effects, right? Those are kind of tied together due to the fact that antimuscarinic effect causes the antiemetic effect, basically, right? Now compare that to the second generation agents. Now again, I don't put in here, remember we talked about enantiomers? We talked about how you can have like cetirizine, but then there's also levocetirizine. Clinically, I mean, yeah, you can use them. They're going to work just as well. But again, I don't know if there's any clinical evidence to show they work better than any of these. So I just stick with the big three, right? Because again, they're going to be the ones that are most ubiquitous. They're the cheapest you're going to run into versus some of these more expensive brand name products, right? But the nice thing with these second generation agents is they lack a lot of those side effects, right? So again, if I have that same construction worker who's on the crane, I can give them a dose of fexofenadine or Allegra. They're not going to have any issues with it from a sedation standpoint. May not be quite as potent at treating their allergy symptoms, but it's still pretty good for the most part. Good enough to at least get the job done for them. Okay. Again, cetirizine, fexofenadine, loratadine. The other big thing here, these all are now over the counter, so they're now available. You can go buy them from Walgreens. Again, these are very safe medications. I'd rather, if someone had no medical intervention whatsoever, rather than take these from a safety standpoint than worry about taking one of these other agents, right? Because again, if you take Benadryl, get super sleepy, and then hop in a car, much more likely to get in a wreck than if I had taken like a dose of Zyrtec or something. Okay. Anyway, there's also an intranasal one we'll talk about in just a few minutes here called Azelastine. Now, Azelastine is a nasal product. So what's the benefit of using like a nasal product versus say like an oral, product? Works directly at the site of action, so you limit a lot of the systemic side effects. So if someone uses Azelastine, would I expect them to have a lot of sedation associated with that? Probably not, right? Because again, it's working very much locally. You don't see this used quite so often because most patients, their symptoms are going to be widespread enough that it's very rare they would just have nasal symptoms, but they can get away with using Azelastine if that is the case there. Again, most of the time you're going to run into issues you run into with nasal products is going to be bitter taste because again, anything that goes into the back of the nose is going to go where? Down the throat, right? So again, if it gets in contact with the tongue, basically they're going to be tasting that drug, and that's that bitter taste they get there. And epistaxis can always be a risk as well. Probably not as big of a risk as we're going to see with another drug later on in this section, but it can still be a risk for that. Okay. Now, again, give you some education on how to apply nasal medications here. Again, some of the stuff is going to seem like it's super obvious, but super obvious things may not be obvious to everyone. So just be aware of that. Typically, like what we have them do is obviously clear out their nostrils first, so have them blow their nose because there's a bunch of gunky stuff all in there in the first place. The drug's not going to be able really to get there into the actual tissue where it's going to be acting. So have them blow out their nose, have them tilt their head down. Why do you think we want them to tilt the head down? Yeah, I'd rather them drain out than back and go down the throat, right? Because again, that's just going to increase the amount of systemic absorption once it gets them down in the stomach. Okay. Typically, we'll have them angle the spray away from the septum because that typically is a more sensitive tissue. Again, you can cause nasal trauma with these, so you got to be careful with them, or a patient should be careful with them. And so by aiming away, you're less likely to do damage to that septum. So what we would do is, for instance, if you're shooting into the left nair, we'd use the right hand. So naturally, you just kind of point away, and alternatively, you'd use the left hand for the right nair. Okay. So by using that technique, again, don't tilt the head back because again, this is going to get the drug going down the throat. And again, this may seem obvious, but make sure they clean the tips off of that. Also, I would recommend not sharing with their buddies because again, they're just going to spread their cooties around potentially. Not good. Okay. Obviously, if they have any kind of nosebleeds, typically they're pretty self-limited, but I would recommend they not use the product anymore and follow up and see if they need something else to help treat those things. Okay. Those are the big, at least counseling points if you're using like a nasal product. Okay. Any questions so far? So I have a scant 22 slides left. We can do this in 3 minutes, right? No. So we have one class session left before the test. I'm going to finish this section up, and then we'll do the Kahoot review. Any questions before I let you guys go? If not, have a great day, and I'll see you all later.